So I'll just get started. So yeah, the crucial role of primary care. Um, oh, there we go. So no disclosures. And so the aimed and objectives today. So why is primary care so crucial in addressing this diagnostic delay? Um, and what are the public and clinician barriers to axial SpA identification? Um, We'll look at the NAS Gold Standard, the Act on SpA campaign, and the creation of their primary care champions, and how we're going to be aiming to achieve this 1 year target of symptom onset to diagnosis in axial SpA. And really, the hope for me at the end of this talk is really just to try and hopefully to improve the understanding and recognition in the latest axial SpA signs and symptoms, for improved awareness around both the public and clinician resources and signposting tools around axial SpA, and hopefully to instill engagement to embed axial SpA screening within primary care settings, and so that we can all become hopefully part of this social movement. So where is the biggest delay? Well, I think the clue's in the title today, but the reasons for the diagnostic delay in AxSpA are multifactorial, which we'll go into, but from the research carried out with NAS and its collaborators, the largest portion of delay is about 5 years, and that's between the symptom onset and then referral from primary care. So the two biggest hurdles really are the first one being the significant lack of public awareness around the disease and its signs and symptoms. And the second is the ongoing lack of consistent recognition with all healthcare professionals in primary care on what the signs and symptoms are. So by delving a little deeper into understanding why this is, as primary care clinicians, we can start to address this diagnostic delay. But obviously we know back pain in the population, axial SpA versus low back pain. Well, if we take the first hurdle, which is the public, a person with back pain does not realise that it might be AxSpA. So axial spondyloarthropathy represents a relatively uncommon cause of a very common symptom, which is chronic low back pain. Low back pain, about 80% of the general population will experience it within their lifetime. So it's a huge issue. And in primary care, it accounts for about between 3 to 7 million GP consults every year. So it's huge. And it also accounts for the most common cause for absenteeism and work loss in the Western world, affecting about 75 to 85% of people either off work or off sick due to low back pain. So, however, although it is, axial SpA is relatively uncommon, yet 1 in 200 of the adult population in the UK will have it. And that's still twice as many as MS and Parkinson's combined. So 1 in 200, to put it another way, 5% of all chronic low back pain will be axial SpA. So it's rare, but it's really not that rare. And it's estimated about between 7 to 15% of people presenting in general practice with back pain will have features of AxSpA. But the problem is 91% of the UK population have never heard of axial SpA. So that is a big challenge, and 8 out of 10 people were unable to identify the symptoms associated with it. So it makes sense that about 40% of axial SpA individuals, they don't seek healthcare professionals within a year of them developing their symptoms, which is what the gold standard is trying to achieve. So what's the impact for the individual? Well, this infographic that NAS made really kind of hits home the individual costs for each year that there is a diagnostic delay. And you can see also that it's a young person's disease, with the average age being about 26. And that's round about the important time of their life. They're trying to develop, forge new relationships, starts family or building careers. Um, and the individual costs, as you can see there, whether it's through losses through unemployment or unpaid sick leave, is over 120,000. And then obviously with those delays, you can then that has the impact on the multiple appointments that are required and the impacts on the NHS. So NAS estimates that, the waiting diagnostic cost per person is over 185,000, with obvious quality of life and mental health effects alongside this. So reducing this would have a huge impact and would save over 167,000 per person. I think it might even be more, but there's still little known outside the medical world on this, and that's what NASA's trying to change and challenge with its campaigning and publicity work. So this is also just an infographic on as we mentioned, the impacts on the UK economy. And so there's the delay in diagnostic in the UK economy, it's 18.7 billion a year. So for every diagnostic year of delay, that's the impact it has. And on an NHS that is really trying to become more cost effective, this could have huge implications. So as I said, there is this Act on Axial SpA programme, and this is the vehicle for NAS to try and deliver their gold standards campaign. And what they've looked at is the sort of bottlenecks of patient journeys, where they're following them from symptom onset right through to their diagnosis in rheumatology. And the area that we'll focus on today, obviously, other than the public awareness, is obviously in primary care, which are the first two on that a diagram there on the right. So in relation to public awareness, they've developed a symptom checker, which is based around the NAS guidelines and the more consistent features of Axial SpA. And they basically just click through the questions, and that produces a PDF file that they either get emailed or they can print out and take to their consultation to prompt these discussions. And it comprises of 8 questions. So identifying the age at which it started. We talk about chronic low back pain. When we talk about that, we mean more than 3 months. And therefore, they might be coming to you in their 40s, but when did it start? So if it started before they were 40, that's still relevant. Obviously, did your back pain develop gradually? So this in serious onset. Has it been more than 3 months? This could be intermittent. It doesn't have to be constantly present for the 3 months, but this episodic, coming for a few weeks, resolving, coming back. So they click through all of these, and that gives them the sort of probability and helps prompt the discussion to take at their consultation. What I haven't included, as well as the patient symptom checker, is also the other public awareness campaigns. There's great videos that they used actors and people suffering with Axial SpA to do promotional YouTube videos on Axial SpA and being more aware, and signposting to the NAS website for more resources. And they've also recruited more sort of prevalent public figures. So we've got somebody that was in the X Factor, Talia Dean, who suffers from it, and she is quite prevalent on social media, really trying to promote it as well. So these are the things that they're sort of focusing on to try and get these people into primary care in the first place. So going back to this sort of total diagnostic delay picture, they arrive in primary care, but there's still a bit of a delay. And this is still an issue for us. So why is that? So what are the barriers? Well, essentially, there's lots of barriers, and it's not an exhaustive list, really. But there's still, certainly for GPs, there's a lack of time in the consultations due to the complex medical needs. And so sometimes back pain that gets more of a, it's possibly given less of a priority if they've certainly got other more pressing medical issues that they've come with a list of. But also the lack of continuity in care. They might come to one healthcare professional for their back, they might come to somebody else for their bowels, they might come to physio for a tendon issue. So this lack of continuity in care can mean that they're seeing multiple clinicians. And there's variability also that can be in the electronic recording and coding of the consults, which can also kind of lose the thread that would normally flag up that axial SpA diagnosis as a possible differential. And this is reflected across much of the literature, not just in the UK. And as I said before, it is really common back pain. And whilst we identified that research showed that there was a large portion of primary care clinicians that were aware of inflammatory back pain, their sort of knowledge and confidence in being able to assess it appropriately was much less. So there were several studies that indicated that clinicians felt this was due to a lack of formal diagnostic criteria or clear biomarkers to support diagnosis. And there's still a lot of evidence that has also supported the fact that educational institutes are still teaching quite long, outdated evidence around the latter stages of AxSpA. And this, so we're missing much earlier presentations of the disease process. And also there's a lot of evidence out there that shows that clinicians are really not aware of a lot of the various screening tools available to support their clinical reasoning during consult. Half of clinicians in the second reference at the bottom of the slide just now, they identified that about half of clinicians had never asked about extra-articular manifestations or peripheral joint symptoms associated with it. 3/4 had never inquired about enthesial problems or uveitis that were associated with it. And about half had also never asked around any family history of either AxSpA or its associated seronegative conditions. So to understand why these issues continue to contribute to the diagnostic delay, we kind of need to do a wee revision, review the current signs and symptoms and the tools and resources that are out there to assist clinicians in primary care to try and help increase the index of suspicion. But let's do a wee revision session first and trying to clarify the difference between the more common mechanical versus inflammatory back pain signs and symptoms. And then we'll move on to the facts and figures. So, okay, so, sorry, I couldn't remove this. This was from a previous old presentation I used to do for the FY1s. And I can't get rid of the little animations. Oh. So mechanical versus inflammatory back pain. So your mechanical back pain signs, well, that kind of is the umbrella term. It can happen in any age because it can be related to radicular symptoms or it can be related to degenerative. That can improve with rest. A lot of the time, if you're not moving the area that's inflamed or irritated, it's usually a bit better. But if we can focus on the right-hand side, the inflammatory back pain signs, it's usually a very specific age range where the symptoms develop and start. It's usually of insidious onset because there is this just, there's not been any preceding trauma. One of the bigger key features is night pain, so broken sleep during the second half of the night, which is a real key feature in inflammatory back pain. So it's a really good one to ask about. Sometimes mechanical back pain, yep, they might have sleep disturbance, but it's usually more maybe trying to get to sleep, but once they're asleep, they're usually fine. And these other key features where pain doesn't improve with rest and it improves with exercise. So again, that ties in with the younger age group and that kind of muddying of the waters where because they're active, because they're still able to do their sports and what have you, then it can be misdiagnosed as more of a sports injury or what have you. And it usually lasts more than 3 months, but as I said before, it can be intermittent. So they will have had it for a longer period of time because we have to exclude that more common episodic back pain that we discussed earlier. And although they also can respond well to anti-inflammatories, that is maybe a sweeping statement. And when somebody's in a roaring flare, it maybe touches the sides a little, but not always as effective. But it's worth keeping in mind. So NAS came up with a little acronym, spine acronym for clinicians and also the public and their sort of poster campaigning and thing, which kind of helps with reminding of these consistent features. So spines, symptoms starting slowly, pain, where is it? So it's in the lower back. It improves with movement, this second half of the night time waking, and this early onset. And interestingly as well, which is less mechanical in nature, is this alternating buttock pain, which is seen in about 12% of patients with AXPA. And the reason for that is if you think of mechanical back pain, say if it's a peripheral nerve, it follows that nerve route. So it's generally always on that particular leg. Whereas if it starts in one buttock but then flips to the other, but they don't have any neurosymptoms, that's a little bit more atypical. So you might think that'll pique your interest with it being more of an inflammatory pain picture. So if we can just kind of do a wee reminder of what the spondyloarthritis group is, it's a family of related conditions with some common features that overlap. And predominantly it's pelvic and spine inflammation causing pain and stiffness. They have enthesitis or tendon pain. And some have a genetic marker of this HLA-B27, which I'll go into a bit more detail later because it's not definitive. And it can also be predominantly peripheral, although this would still be classed as a spondyloarthritis. And the overlap you can see just on that diagram there. So if we have a wee look and just unpick some of the things that we know, we've mentioned that it's much more of a younger person's condition. The big thing also to remind or to sort of refresh or even highlight for people that aren't aware is that it affects the same number of females and males. And we're aware of the scoping that NAS has done, that this is still a misconception, that it's a male-dominated condition. It's a seronegative arthritis. So again, it's part of the family that is rheumatoid factor negative. And again, this can sometimes, they can be negative for that. And this becomes a misassumption that they don't have an axial SpA. The other thing that's really important to note is that the radiographic, i.e. the X-ray positives and the non-radiographic subtypes are roughly equal. And as I said briefly, there is no definitive test. And because of this diagnostic delay, because of the lack of public awareness, because of the multiple barriers within primary care for clinicians, this can really have an impact on the individuals. And it's been shown that 59% of people with AXPA report experiencing mental health problems compared to other musculoskeletal conditions. So it's a big issue. Other features, as we mentioned, the good response to anti-inflammatories, tendon pain, the family history of AXPA. So first-degree relatives are a big indicator as well. A raised CRP or HLA-B27 positive. Those two I'll go into a wee bit more detail in subsequent slides. But other things like psoriasis, inflammatory bowel disease, such as Crohn's or colitis, and anterior uveitis are also associated with this condition. So these extra, I used to call them extra articular features or extra musculoskeletal manifestations, EMM, axial SpA, they're really common. And they're also really important features of AXPA to help you come to your conclusion, your diagnosis or suspicion of AXPA. So questions around this in the consult can make a big difference in which direction you go. So they've listed them there. The most prevalent are things like your uveitis, enthesitis, where there's inflammation at the enthesis. Inflammatory bowel disease is at 7%. Psoriasis is about 9%. And what we know actually for people that just have psoriasis, 1 in 4 will develop a psoriatic arthropathy. And with dactylitis, that sits about 6%. So these are all important to ask. These are just some common sites, axial sites for tendinopathy in people that have AXPA. And so, it's maybe worth noting in certain areas because it's less likely to be something that's a cause for a repetitive strain, say. So it's worth taking a note, and especially on the peripheral sites. So obviously in AXPA, it can be right up to 44% can have greater trochanter tendinopathies. Also the shoulders, quite a prevalent one, and plantar fasciitis and Achilles tendinopathy there as well. So we kind of alluded to the fact that men and women have actually got the equivalent number of people that suffer from AXPA. So it's no longer seen as a male disease, but females have a 2-year on average longer time to diagnosis. And this isn't just in the UK, this is around the world. And there's a few reasons for that. Men with axial SpA show a higher rate of radiographical progression compared to women. So they will be more likely to present having positive X-ray changes. Whereas non-radiographic axial SpA is much more prevalent in women. And that's 67% versus 33%. So there's quite a significant difference between the two. So ankylosing spondylitis, which is the latter stage, or radiographic axial SpA, this is the one that's more prevalent in men. And this is the one that is still taught as being the one to look out for in the general population. And that's why women tend to get missed, because their X-rays are clear and they're female. But women are shown to have, in general, higher disease activity scores. And they're also shown to have much more peripheral manifestations compared to males. So they're more likely to have enthesitis, inflammatory bowel disease, psoriasis, and peripheral arthritis as well. And interestingly enough, and this kind of dovetails quite nicely with the previous speaker, Patsy's discussion around fibromyalgia, because about 25% of AXPA sufferers are positive for the Fibromyalgia America College of Rheumatology criteria. And so fibromyalgia does coexist with axial SpA. And so that also goes away to explain why women can take a bit longer for a diagnosis, because they have these other features. So it can be misdiagnosed as fibromyalgia, but also what we've heard from Patsy is that obviously menopausal symptoms can also flag that up. So joint pains, fatigue, night symptoms, poor sleep, these are all also associated with other conditions such as menopause. So again, this is also why it's a lot harder and longer for women to get the diagnosis. So let's go into a wee bit more detail about the current investigations that we do have to our fingertips. The HLA-B27 genetic marker. So investigations really, before we go into this, it's not really required for a referral to rheumatology, but it can inform the referral. But because of the erroneous beliefs around the condition, the risk of doing bloods before the referral is that negative results may prevent a referral. So whether that's blood results or imaging results. And while a high proportion of people with axial SpA have the HLA-B27 gene, only about 7% of people with the HLA-B27 go on to develop AXPA. It's a bit confusing. And it's carried by about 8% of the white European population. So it does not predict disease, and its absence doesn't rule it out. So rheumatologists don't like to use that as one of your kind of diagnostic criteria generally because of the prevalence of it. And they're much more, the weighting on other signs and symptoms and features are more likely to instigate the referral. And lots of people with AXPA will have also normal inflammatory markers. So ESR and CRP are only raised in about 50 to 70% of people with AXPA. So the sort of 30 to 50% that have negative inflammatory markers, again, it's not an indication that they don't have the condition. Unfortunately, a raised CRP is actually also been associated with a higher and poorer prognostic outcome in AXPA. So if they have got a high CRP, that also indicates that they might progress much more. So the NICE guidance still kind of mentions X-rays of SIGs, but in England, the Getting It Right First Time pathway states the X-rays or MRIs, which is good. And this is helpful because we know now that there's a huge proportion that are non-radiographic. They're not going to have changes on their X-ray, but they might still show changes on their MRI. And they would benefit from early treatment. And also, we have to keep in mind as well, because of the young age of a lot of them, including women of women of childbearing age, X-ray in the pelvic and spine is kind of really undesirable, to be fair. So imaging, it can take 7 to 10 years to detect radiographic changes. So again, this is another big reason why MRI needs to be the gold standard. And thankfully, the more MRI has become prevalent, the cost for using it has gone down. And ordering the whole spine and SIGs and requesting the Stern T1 sequences are what is the sort of gold standard. And it's worth noting for those that can organise MRIs in primary care that if you're requesting a MRI with the Axial SpA protocol, that you should be asking patients to stop taking their anti-inflammatories a couple of weeks prior to the MRI because it can suppress the inflammatory changes in 1 in 4 people. So that can kind of mask, they can have a false negative MRI if they continue to take it in some instances. And also it's worth noting that 12% of MRI SIGs can be clear, but they can have changes higher up the spine. And that's why it's really important to ask for SIG and whole spine. Okay, so this is the pathological sort of process and progression over time. And I quite like the ESIS diagram on the bottom. As I said, 2009 was probably the first time that MRI was used rather than X-ray and became part of the sort of official classification criteria for AXPA. And what you tend to find is that, you can see here that early in the timescales, there's not any kind of bony changes, and therefore that's where we want to catch these people, because if we catch them before there are any bony changes, the medications that they can start, the sort of disease-modifying medications prevent any sort of ankylosing in the future. And therefore, it's really important that we try and prevent that process from happening. And so, as we said, women can bounce around between that sort of inflammatory, fatty repair tissue process, and they don't, as many of them, move into the syndesmophytes and the ankylosing spondylitis, which men tend to do more. So when should we request MRIs? So you should be always requesting SIG and whole spine. And all eligible patients with suspected AXPA should have an MRI as part of that diagnostic assessment. And whether that starts in primary care if we have access, or if that's done as part of the first appointment once they are referred into secondary care. And as I mentioned, what are the key radiological features that make a diagnosis? Well, they look at the spine and the SIG. They're looking for corner inflammatory lesions. They're looking for multiple corner fatty lesions or new bone formation. And in the SI joints, they're looking for bone marrow edema, fatty infiltration, or in the more progressive stages, erosions or new bone formation. So it's really important that we also make sure that because of the what we're asking and the type of sequencing we're asking to do for suspecting axial SpA is making sure that it's reported by an MSK radiologist as well. So we move on to the Act on AXPA campaign and the Primary Care Champions Programme. So basically NAS, as we kind of touched on at the beginning, they were looking at the sort of four bottlenecks for the diagnostic delay. And so because primary care seemed to be a huge part of that delay for patients, what they wanted to produce was a cadre of champions that were based in primary care, whether that was GPs or first contact practitioner physios, based in primary care, by basically driving up the awareness across primary care, and trying to raise the profile of AXPA, ensuring that it's higher within the clinical reasoning and leads to the identification and urgent referral to rheumatology. So the programme consisted of leadership development and quality improvement training over 2 years. And then we all, 10 of us, carried out local improvement projects locally. And that was all completed. So we finished that in July with a celebration event presenting our quality improvement posters. And there we are, there's the motley crew, and I'm sure you'll be able to see Sam there hiding in the back, and I believe, so Lucy McCann putting a comment on the chat earlier, so hello to you, Lucy. So this is the motley crew. So we're spread out throughout the UK. I'm based in Scotland, Jenny's based in Wales, and then the rest are spread throughout England. And we've been really lucky to get 2 GPs also involved as primary care champions. So we've got a good spread of people. And so the sort of variety of things that we were doing, we were looking at increasing the awareness of AXPA in primary care. So whether that was sort of looking at education within our locales or developing learning modules, or indeed doing things like this. And also looking at improving identification and screening in primary care. Also looking at screening tools, so the SPADE and the Primus, to maximise the efficacy of patient consultations. So there was a couple of primary care champions that looked into that, and trying to improve referral pathways to rheumatology. So that was a big part of my own one. Although I was part of I'm in the biggest health board in the UK, we were the only health board that advanced practitioner physios couldn't refer directly to rheumatology. So that was the big challenge for me. And providing personalised care to AXA SpA patients, and also utilising best practice guidelines for identification and referrals. So there was quite a lot that we did. So I mentioned some of the screening tools. So the SPADE tool is basically been designed to assist medical professionals and define the probability of axial SpA in a patient with chronic back pain below the age of 45 that's got no definitive changes on X-ray. And it's a free online tool, and it can be used by all healthcare professionals. So even if you just type in SPADE tool, then it will come up. And you can see from the first screen here that patients with chronic back pain, you basically just tick box all the ones that apply to them. and then it will come up with where on the graph they feel it's relevant. So you can see there's either the definite diagnosis of AXPA, which is they're very likely to have it and you should refer immediately. The probable diagnosis, which again is that they still need to be assessed by a rheumatologist, so you would still refer. Additional tests, so they may have AXPA, but further tests are necessary, but they still recommend that a rheumatologist is involved. And this is a bit more relevant for what it became apparent to me when we were meeting up from all over the country as primary care champions, was that a lot of the screening tools, we don't have access to MRI in primary care, and we didn't have access to HLA-B27. So actually, for a lot of people that were probably more likely to have it, they were still sitting in the additional tests. And then obviously the bottom one, axial SpA, is improbable. So they suggest reassessing for an alternative diagnosis. And then you've got the Primus tool. So this is basically being developed in collaboration with Raj Sengupta, who's one of the consultant rheumatologists at the Royal United Hospital Bath, and Novartis Pharmaceuticals, and they developed a pop-up tool that was integrated into electronic patient records to support the early referral of patients presenting with signs and symptoms of AXPA. And that was kind of based around the ACES inflammatory back pain score. And it was designed to be non-intrusive. It was carefully optimized to avoid alert fatigue, which we can get with a lot of pop-up tools during our consults. And the AXPA alert and template are only launched when a specific combination of existing codes are combined with those entered in a consultation. The toolkit includes a reporting tool that tracks trigger activity and identifies patients that meet the ACES inflammatory back pain referral threshold. This wasn't something that I was able to do in Scotland, as it was not compliant with the electronic patient records that are used in other health boards, unfortunately. But this was successfully implemented by a few of our primary care champions down south. And so the referral thresholds then, the NICE guidelines have got a really good, clear, concise way to help with your clinical reasoning. And the BMJ developed a sort of flowchart infographic that's really useful. And I have got all my sort of GP colleagues and physio colleagues, they just have it printed off and on their wall to help facilitate that consult. And there's also the ACES guidelines that we mentioned there, and that's what the Primus tool uses as a basis of the sort of prompts. And we mentioned the Getting It Right First Time programme, which is this national NHS England programme that's designed to improve the treatment and care of patients through in-depth review of services and benchmarking, presenting a data-driven evidence base to support change. So obviously it's really clear there that if somebody either uses the self-screening tool through NAS, or if they just present with symptoms that they're unaware of that might be AXPA, then obviously the advice and guidance is listed there in front of you. And it also refers to the SpA tool, which we've just recently mentioned there. So in Scotland, we don't really have a sort of national guidance. It's more Health Improvement Scotland and the Right Decision Service of kind of more of a platform for local guidance and pathways to be put on the one website, rather than it being one national pathway. And ARMA also have started looking at musculoskeletal health inequalities. And this was developed in all the devolved nations, and I'm pleased to say that on the 5th of December they're launching the publication of the Scottish summary on the Act Now part of the MSK Health Inequalities paper. And that report offers practical guidance and recommendations for health systems, MSK services and practitioners to implement. strategies to overcome barriers to healthcare access and tackle inequality. But it also, which is relevant to us, is it spotlights organisations that are already implementing innovative ways to engage those underserved groups, such as AXPA. And just briefly, what I wanted to highlight were what the challenges and successes of the primary care champions were. So the challenges were how to address the difference in the sort of local and national pathways, barriers from stakeholders and secondary care services in implementing any change, whether that was to do with pathways or IT systems, and obviously the digital healthcare variability between nations and its impact on pop-up tools. Other challenges were collaborating and producing educational material, with this sort of geographical challenge with us all spread out, and how to achieve the broadest reach to determine meaningful change for any learning and education. But there was lots of successes and there's still more to come. So producing educational resources, videos, presenting at numerous local and national events like this, and a therapy expo as well, and MIMS. And also we were able to achieve more collaboration between primary care and rheumatology services in all our localities. And creating the first direct rheumatology pathway from APPs for the largest health board in the UK felt like a bit of a win. And achieving installation of the pop-up tools within local primary care partnerships was another. But as I say, there is more to come, and one of our primary care champion GPs is looking to update some of the training in some medical universities, and also for the 14 Fish training platform as well. And I'm looking to look at the digital training platform that's Learn Pro NHS Scotland to provide a module on inflammatory back pain as well. So, and the reason I wanted to highlight these examples was to help those of you that are watching today and are spurred on to consider what you could maybe take back to your own local primary care setting, really. And but fear not, NAS has a lot of online resources that can help. Now, I didn't manage to fit them all on here because it would be far too busy a slide, but the Act on AXPA website has got a toolkit for all healthcare professionals. You've also got an online module for designed by the Royal College of GPs, and that's got CPD credits for that as well. And there's loads of resources that you can use, and also all the presentations that we've done you can take back to your locale to use. But these are just a snapshot. We've also got the podcast as well. So the take-home messages really today are really just that AXPA is more common than you or the public think. It does affect males and females equally, but they can present with a different bias of clinical features. And it's estimated that about 5% of all chronic back pain in primary care will have AXPA. So it's just kind of being aware of that. And the William Osler, the famous physician and founder of the bedside teaching, he said once that listen to your patients, they're telling you the diagnosis. So it's just about asking those really relevant questions around inflammatory back pain and the associated features of AXPA. And it's just remembering that change is possible. Just start somewhere, follow it everywhere. And all healthcare professions involved in dealing with chronic low back pain should have an index of suspicion. And NAS does have a really wide wealth of resources for all healthcare professionals in primary care to help facilitate earlier identification. So as I finish the presentation, I really hope I've planted a seed for all of you to just think about what you could do to raise awareness within your own localities, whether it's just obtaining free posters from NAS that you can put in your waiting areas, or including AXPA as a topic for one of your own regular in-service training events or CPD self-directed modules, or exploring whether the pop-up tools might be something that you would be interested in installing or using. But whatever it is, collectively, I think we could make a real impact on these patients' life and allow them to live a life they want to live rather than being dictated by the limitations of their condition. And we cannot then aim to really support NAS in their ambition of 1 year to diagnosis.
Thank you very much, Kirsty. That was very thorough, a jam-packed 45 minutes, but definitely food for thought. And I love all of the tools that are coming in place, because you
Yeah,
haven't got long within the consultation, and you've just got to make sure you're asking the right questions and actioning from there, really, isn't it? And it's about the continuity, like what you were saying, is sometimes you request bloods and then they don't come back, they go to somebody else, and then somebody else says they look normal, so they don't put it with the clinical picture, and then the patients just slip through the net. But absolutely amazing with the advanced practitioner referrals to rheumatology as well, which I think will really significantly shorten the length of time waiting for people to get the rheumatology input that they really need, isn't it?
yeah, absolutely.
Absolutely amazing. Thank you so much.
No problem.
Um, and I don't know if anybody's got any other questions, but there's nothing come up on the chat there.
Oh, well,
But
that's either a good or a bad thing. I'm not sure.
good. Oh, there we go.
Oh, good. Thank you.
It was just a very thorough and extremely helpful presentation, Hugh was saying there. So that was
Oh, that's
pretty
kind.
amazing.
Thank you, Hugh.
It certainly sounds like there's lots in the pipeline from a NAS
Yeah.
point of view, especially the primary care champions as well. It's absolutely amazing the work
Yeah, and we would
you
really encourage anyone that's inspired today to just reach out, because NAS are really keen to get more people involved. And, we're just planting the seeds as champions. It's really about, well, and not reinventing the wheel. If anyone is interested about it and what they can do, they don't have to do the same thing. They can speak to, well, how did we manage to do it? And therefore, we're happy to sort of support them in that. And yeah, Sam's just said that Claire Clark and the NAS can help, and it's on their website. So yeah, absolutely.
absolutely brilliant. Thank you very much.